Well, good morning, everyone. You are all very welcome to our webinar. We are going to talk gathering strengths against antimicrobial resistance. Today, we have representatives from all over the world in this webinar. My name is Renata. I work with General Coordination of Public Health Laboratories together with Dr. Abreu and Deborah Cooley that is fighting for antimicrobial resistance. I wish you all a very nice event. Welcome you all. And now I will hand it over to André. Thank you, Renata. Good morning, good afternoon, everyone. First of all, I would like to thank you all my colleagues from the International Centers for Antimicrobial Solutions, the colleagues who are here representing projects in several areas from the antimicrobial resistance. We have here Brazil, Chile, Georgia, in order to show the need of this partnership to make advancements in our actions, our commitments from the political declaration, the General Assembly of the United Nations, which took place last year. Antimicrobial resistance is still and will still be a subject which is really relevant, public relevance, and also the impact on public health. And this webinar is intended to show that working together, joining forces, we will be able to make advance with that. Another important aspect I would like to highlight is that today, April the 7th, is considered the World Day, the World Health Day. And talking about antimicrobial resistance on the Health World Day is extremely relevant to show the importance of these joint actions in this area. And I would like now to hand it over to Dr. Sujith, Chandy, Director of ICARS, who I have the huge honor to be a colleague at SEG AMR from the World Health Organization. Sujith, the floor is yours.
Thank you very much, André, and thank you very much to Brazil and the entire region for organizing this very important webinar. I think if you look at the whole issue of microorganisms and bacteria have been here for eons, whereas antibiotics, we've been fortunate to have it in the last 100 years, if I might put it that way, and a lot of lives have been saved. But unfortunately, as is always, when we have too much of very good things, we often tend to misuse it, inappropriately use it. And it has been the case with antibiotics and antimicrobials, unfortunately, where due to various factors, the bugs or the bacteria and the other microorganisms are fighting back for survival. And therefore, we are in a particular situation where the pipeline of antibiotics has dried up. But of course, there are efforts on for more research and development, but the number of effective antibiotics has decreased remarkably, which means that the next time any of us have an infection, will we be reaching the post-antibiotic era? And that is why this particular phenomenon, this particular issue that we are grappling with and discussing today, antimicrobial resistance or antibiotic resistance, is of crucial importance, not just from a science point of view, but from a community point of view, from a government point of view, from an economics point of view, and most important, from an existential development point of view. Therefore, if we don't come together, the bacteria will. And that is the essence of why it has been so important to come together from multidisciplinary areas, multiple sectors, and most importantly, across the world, because we know that bacteria and AMR really don't have any boundaries. But I'm so thankful that this has been organized, because partnerships are crucial across sectors, within sectors, across boundaries, within boundaries, if we are to truly tackle antimicrobial resistance in a holistic approach. If we do not do that, unfortunately, the game is lost. And when I say the game, I mean it in real life. People's lives are being lost as we speak. And therefore, we need to be sure that we create the right models in contexts where it is difficult. We should not kid ourselves. And the partnerships are important, and the regional learnings, which are in Latin America, is extremely important in order to understand that things can be done successfully if we come together. And with that brief opening remark on behalf of the International Center for Antimicrobial Resistance Solutions, Sujith Chandy, as Executive Director, thank you very much for inviting me to this very important webinar. And I'm sure the illustrative examples from the various countries will inspire not just words, but actual action on the ground. Thank you very much.
Thank you, Sujith. Renata. Thank you, André. Well, I would like to thank for André and Dr. Sujith words in this opening of this webinar. And now taking the opportunity here just to mention that for microbiologists in the country, this weekend we had an event to update the cohort table. So it's available on the website of PRCast, where in this opportunity we discussed a lot, especially when it comes to microbiology, the action of the microbiologist in the laboratories. So I invite you all to access and update your files and the modifications, the changes from last year to this year in the microbiology labs. Well, so I think that we can now start with the lectures, André. Yeah. So for this first lecture, I would like to invite Dr. Sujith Chandy, who is the Executive Director of the International Center for Solutions of Antimicrobial Resistance, and he is going to speak a bit about the advances from declaration to implementation in the United Nations.
Thank you very much. And once again, for this opportunity to speak to all of you. I'm going to speak for the next 10 minutes or so on the issue of moving from the declaration to the implementation. Next, please. So if you look at this particular slide, 2024, the last 1 year, has been a significant year for AMR, or antimicrobial resistance. Of course, right from the 40s onwards, when Alexander Fleming discovered, and then therefore the antibiotics were introduced, it has been significant years. But as I mentioned just earlier, things have not looked good in the last few decades, especially from the 80s onwards, where the pipeline of antibiotics ran dry. There have been collective efforts towards improving the situation with various activities on the ground across the world. But there had not been a very cohesive approach till around 10 to 15 years back, and especially 10 years back when the Global Action Plan for Antimicrobial Resistance was developed, and then the national action plans in various countries. But unfortunately, except in a few countries, there have been a lot of efforts in different countries, but not much movement or very concrete action on the ground for a number of reasons. And therefore, in 2024, the United Nations came together once again to talk about AMR. And that led to this entire list of activities and potential commitments under the umbrella of the UN General Assembly Declaration on AMR. So that's a very important, significant event which happened last year. And along with that, of course, various regions, including the G7, the G20, the G77, BRICS, also had their mention of the importance of doing something about AMR. And last but definitely not the least, the ministerial high-level meeting in Saudi Arabia and Jeddah, where certain commitments were discussed as to how this move from declaration to implementation should occur. Next, please. But the real question is, if we need to move from declaration to implementation, what should we be doing? And we at ICARS have been trying to do our bit for the world, for the countries, especially the low and middle income countries, in trying to understand what are the barriers and what are the issues that people on the ground need to grapple with in order to achieve implementation. And for us, there are 6 specific things which are important. One is country ownership and priorities. Why country ownership and priorities? Because unless we take ownership of something that we do in our own life, that we believe in it, that we are able to then sustain it. Whereas if that ownership is not there or the priority is not there, there are many other competing priorities and things get lost. Similarly, for countries, that ownership and priority has to be there. Secondly, capacity strengthening. We need to be ensure that people on the ground are empowered, enabled, and have the capacity to move forward with activities to contain AMR. Third, we should have an approach to ensure that there is adequate financing for AMR. Otherwise, many of our activities will stand still. Fourth, we understand that AMR is not restricted just to human health, but also to animal health, to agriculture, to food security, to environment. And therefore, it is very important to be able to coordinate various aspects among the sectors, ensure that no sector is left behind, and have a One Health approach. Fifth, we need to ensure that whatever we do, there is a methodology to it, and there is a way to understand what are the things which may work, the intervention, and what are the things which may not work. And if it doesn't work, why not? What leads to behavior change? What leads to a good economic case? And therefore, intervention and implementation research. And last but not the least, there is nothing we can do alone, especially when we deal with a complex phenomena with multiple contributory factors such as AMR. Therefore, partnership and collaboration are extremely important. Now, as I go into the next set of slides, I'm going to take each in a bit more detail because I think it is crucial to understand this if we are to really move forward from declaration to implementation. And in this slide about context-specific solutions, even within Brazil or any part of Latin America, there are differences between urban and rural, government facilities, private facilities, the farm sector or human hospitals. And therefore, each context will have its challenges, but also solutions which need to understand the challenges in order to move forward. And that is why this whole theme of context-specific solutions is extremely important. On the right of the slide, you will see one paragraph from the UNGA Declaration showing that national ownership is extremely important. But also, if you look at that second line, the primary role and responsibility of governments. That is why we in ICARS truly believe that if we need to do a project in a country or show something which is working, we need to ensure that there is ministry level buy-in from the start. Because then we know that if a successful model is evidenced, there is much more at stake in ensuring that things can be sustained beyond the project and, most importantly, to be able to scale up in the rest of the country or in the region. The second thing is that our projects are very important that we discuss with countries the priorities that they have in terms of AMR burden, in terms of the challenges they have with the National Action Plan, in terms of many other factors which could be within sectors. And therefore, this conversation, a prioritization exercise, becomes extremely important. Many countries have developed national action plans, and those priorities, therefore, have to be done because sometimes it's difficult to complete everything in one shot. But we need to go also not just with the ministry and not just with the researchers and the academic institutions from the project point of view, but also to the communities that we serve. And we in ICARS truly believe in a community-based approach. And we have examples like the responsive dialogues and farmer field schools, where we have engaged and trained farmers on biosecurity practices and on antibiotic use approaches with the responsive dialogues. Next, please. But truly speaking, we are in a world where things often change. There's attrition in employment. There is people who are moving up the generational ladder. And therefore, this focus on strengthening capacity in various sectors to be able to deal with AMR is crucial in our national action plans. And therefore, we truly believe in a multidisciplinary team, and all our projects have that multidisciplinary team. Whichever sector you're working in, there needs to be somebody in economics, there needs to be somebody who's trained in social sciences, there needs to be somebody who's trained within that sector, but probably with different experiences. And unless we do this, often we find that many of our projects often in different parts of the world have different levels of success. But if you bring in different teams to cross-fertilize and have an interdisciplinary approach, often it leads to success. And that is why we also ensure from a generational issue that we involve people who are doing their masters, their PhD students, to show that we buy in to somebody who's young so that they have an interest and a commitment to tackle AMR throughout their life. And we also spend a lot of time on virtual platforms and in person to exchange through communities of practice and with our partners. Next, please. So in terms of funding, I know in the last 2 months, especially the globe and the world over has had huge issues in terms of finance, in terms of global health, in terms of supporting education and health and farms overall. And therefore, even in the projects that we do, health financing is extremely important in the national action plans, in the global action plans. What we truly believe is that we need to build an economics case in any intervention and any research that we do in the true holistic implementation research point of view. At ICARS, we think that many countries are able to rely on existing capacities and funding streams. And we need to be able to bring that out with good economic case investments so that the government knows this is worth exploring, scaling up, and to be really sure that this is successful. And that is why all our projects have this inbuilt economic model into it. In one sense, the scale-up of solutions will depend more and more not just on the economic model, but on the partnerships for that model between public and private entities, for example, between stakeholders, between the community and the government. And we truly believe that this funding, for example, in middle-level countries, domestic prioritization is extremely important. Otherwise, often we need to be able to be sure that we integrate into existing finance systems in a country. And all that discussion is happening as we speak with the next version of the Global Action Plan. But rest assured, if we don't put in an economic model or economic research into projects, often the question will come, even if you have a successful model, is it worth investing in? And that's why that economic part is so essential. Next, please. The One Health approach, we talk much about it, but the real question is, how much of a focus do we have in ensuring coordination between the sectors? Secondly, not blaming other sectors, but looking at our own sectors and seeing how best we can move forward. And three, ensuring that there is finance in each sector so that activities in each sector can go forward. And last but not the least, not leaving any sector behind. I think every sector has a role to play, and we know that AMR does not hit one sector alone. And within each sector and between sectors, there is that interconnectedness. The planetary approach is so important. It is a sustainable development issue. On one hand, we could have a problem in a hospital with AMR, but on the other hand, it could be in the farm. On the other hand, it could be the issue of environment, where most of the bugs and the water interplay. So what we need to realize is, unless we have that coordinated approach, could be vaccination in children, biosecurity in farms, it could be ensuring stewardship in a hospital, but also appropriate use as far as food is concerned. So if we don't tackle things in a holistic manner, there is a chance, and much more than a chance, that we will lose the game. And that is why this point number 9 on the AMR Declaration becomes so important, to have a multi-sectoral, cross-sectoral, and interdisciplinary approach. Next, please. So we at ICARS are trying our best, working with low and middle income countries, partnering with many partners across the world to ensure that we try our best to reduce drug-resistant infections across One Health with country-determined AMR research priorities. That's very important to us, because unless there is that priority coming from within the country, things will not move beyond the project. Generating evidence that work in real life. There's a lot of theoretical research going on in the world, both in AMR and other fields. But unless we are practical in what we do, there will be no buy-in from the communities and the governments that we serve. 3, funding partnerships. And this is extremely important in today's world today. And that's why a broad stakeholder engagement is so important to us. I talked about the intervention implementation research framework, but also what goes beyond the project. And for us, sustainable impact and scalability is crucial. And that's why our model is kind of embedded with intervention and implementation research. To show the challenges, to show that interventions work through an economics and behavioral aspect. Lastly, I think I already talked about, next slide, please, about the needed approach. And this is crucial to us. If we really need to move forward, we need to ensure that there is a buy-in from the government, a buy-in from researchers and stakeholders on the ground professional, a buy-in from every sector, and a buy-in from the community on the ground. If we could get them together to be able to understand, to believe, and to act, I think we will be doing a world of good, the top-down, bottom-up approach. My last slide just is to show that we work with partners across the world, with countries, mission partners. I'm proud to say that Brazil is a mission partner of ICARS, and so along with so many other countries who are represented in this slide. But we also work with researchers, donors, NGOs, with research institutions, and you can see many of them here, and of course the international agencies with WHO, FAO, UNEP, and WOA. And most importantly, we work with you on the ground. And that is shown in the last slide, and I'll end here. These are the projects supported by ICARS across the world in the low and middle income countries with around 150 partners. So we are indebted to our partners on the ground with countries, because they are the real drivers of our projects. And we truly believe that if we come together, hold hands together across sectors, across countries, across professions, and we can do something about AMR. And I look forward to the deliberations as well as the presentations from each country, because I truly think that these are successful models that we need to be able to be inspired with, and that we can move forward knowing that it's not a lost cause. It's something that we can truly contain if we try. Thank you very much.
Thank you, Sujith.
Obrigada, doutor.
Thank you, Dr. Sujith. Thank you. We are following here, me and Débora, the links for
de acompanhamento pelo YouTube.
for
Então,
the
as
YouTube
perguntas, se vocês forem colocando,
channel. So the
nós vamos
questions
lendo aí
that
no
you
chat,
write in the chat, we are going to read here to the lecturers, okay? So just to remind you, please participate, write your questions, your suggestions, your comments, and we are reading them all on the chat. And now, to continue with the webinar, I would like to invite
André Abreu, né, nosso parceiro de
our
trabalho
partner,
CGLAB.
that is CGLAB.
Ele vai falar pouquinho
He is
sobre
going to talk a bit the National Action Plan for Prevention and Control on AMR in Brazil, the success of the first plan and the highlights of the new plan from 2026. Please, André, the floor is yours. Thank you, Renata.
Compartilhando a tela.
I will share my screen now.
Está em modo apresentação.
It is presentation mode now, yeah.
Bom, mais uma vez,
So once again, I would like to thank your participation, everyone's participation. Today, April the 7th, is when the the World Health Day is being celebrated. It's very important to talk about AMR on this date. So just a brief context, even though Sujith already mentioned the importance of the year, 2024, for the global governance actions on AMR, here is a timeline of the year that started with a meeting in Malta and followed by the World Assembly and the agenda 2025, the first meeting of the BRICS in Moscow, AMR International Conference, which also had the declaration, a joint statement of the BRICS on AMR, the inclusion of the AMR on G20 agenda, and also the political declaration on climate change, health, and equity, and the One Health that includes AMR in their reports. And finally, the high level, the ministerial meeting in New York during the General Assembly of the UN with the Jeddah commitments, which was the fourth meeting, which really helped to consolidate all these commitments. These are the declarations, the statements. These discussions, they show the importance of reinforcing the implementation of national action plans, governance, sustainability, funding, and the actions, the ones that are really sensitive for AMR, to expand the access to diagnosis, treatment, quality, to reinforce the surveillance mechanism, multi-sectoral coordination, the impact on the environment, the importance of the environment in the development of these AMR, and also research and innovation. The main goal of these actions is the 10% reduction of AMR until 2030. In a general context, deaths worldwide with,
Nós
according to
temos
recent data,
4,71 milhões
we
de
have
mortes associadas,
4.71 million deaths associated to AMR and 1.14 that are attributed in Brazil. This number corresponded to 138,000 deaths and 30,000 attributed deaths, including AMR, among the 10 causes in the country.
Na América Latina,
In Latin America, this represents 11% of the global deaths and 11.5% of attributed deaths.
de redução da expectativa de vida,
And in the reduction of life expectancy, we have the low-income countries in Latin America with these projections of the reduction in 2.3 years. The global reductions is higher, 11.8. So Latin America are these are the continents that are most affected, most impacted by it.
falando disso, prevenção,
Now talking also
instrumentos de prevenção,
about
prevenção das
the tools for the
infecções, saúde,
prevention of these
elaboração das
infections,
medicinais, ampliação do acesso ao saneamento
also the
básico,
access
tem
to
a
sewage.
capacidade de
These
reduzir
have the
até
capacity of
750 mil
reducing
mortes anuais
750,000 deaths
causadas pela
yearly that are
resistência.
caused by AMR.
Do ponto de vista
From the
econômico,
economic point of
24
view,
milhões de
24
pessoas
million
podem entrar
people
na faixa de
can
pobreza
enter
até
this
2050,
poverty
mostrando
status
que
until 2050, which shows that it's not a microbiological problem, not only health problem, but also with implication in other areas. The environment, climate changes are responsible for these pathogens, the reduction of biodiversity, the development of resistance mechanisms, but also these extreme events, extreme weather, can have some changes in the chain, the supply chain of AMR, and this ends up making the situation even more serious, AMR even more critical.
Essa projeção de mortes atribuídas
These predictions of deaths, attributed deaths, the first scenario that was in 2016, when we launched the Global Action Plan, there was a prediction for 700,000 deaths and 1 million morts until 2050. This was equalized by disease with the work that came to show that the situation is even more delicate. And in parallel, the annual expenses for the control and prevention of AMR are really small when compared to the number of deaths caused by AMR. This is not, we are not trying to demerit or to say that other diseases are not important. All of them are important, but it shows that we still have a long way to go in order to be equivalent when we balance the global expenses with the action, with the importance of this action. In this same context, we also have a reduction of new drugs in the market. This is a timeline that was designed drawn by UNEP, which shows that this AMR is identified a few years later after the drug, which came to show that in addition to producing, developing, and discovering new drugs, the prevention actions, maintenance actions for health promotion and health maintenance are crucial so we can fight AMR. There's data from Brazil, which shows that despite of all the efforts, we still have an increase on the global consumption of antibiotics. These are data from 2019 to 2024, which shows this increase in consumption and also a global increase of more than 20% since 2019, which is extremely concerning. When it comes to investment return, it's 28 to 1. So investing on AMR, sanitation, you really have a benefit. You have a payback for the economy and the reduction of health costs. This study was carried out by the Center for Global Development, and it shows the impact and the need of investing on the prevention of AMR. There is also an issue of the approach, the narrative. When it comes to resistance, this narrative harms the understanding, the discussion, and the sensation of urgency, especially for the low-mid income countries, especially after the global plan until the pandemic. This narrative was based on the topic of treating AMR or silent pandemics, and the focus on preserving the efficacy of the antibiotics. At the second point, especially after the pandemic, you keep, of course, focus on surveillance and the mechanisms to preserve the efficacy of the antibiotics, but then we started approaching also the importance of prevention mechanisms, the importance of treating, access, equity, and the community base of this AMR, not only the resistance in hospital environment. There is a huge focus on the importance of implementation of these action plans, and this is in the declaration, political declaration, the importance of governance, sustainability, and these actions, and the integration among different sectors, different players, beyond borders, with bigger integration among countries. Now, a bit of the plan, the National Action Plan for Prevention and Control of AMR. This was launched in 2018 and is due until 2022 and in force until 2022, but the actions are still being executed. This is why 2018, 2022 plus 2, because they are still in force. Our plan was based on the global action plan with as most of the countries, so the strategic objectives, they have the same line of the global action plan, which is to improve awareness on the existence of this communication, information, to strengthen the knowledge scientific basis with research, reducing this with sanitation and infection prevention, optimizing the use of drugs on human and animal health, and to prepare the economic arguments that for a better, a more sustainable investment. This also comprises the livestock plan and also the health services, which is the responsibility of the Ministry of Livestock and Anvisa, respectively. Here, these actions, the importance of showing what we have done so far during this time, and the importance of showing how the partnerships are crucial to advance in the implementation of plans. The plans, they have the need of a better structuring, implementation, 100% implementation, but those things that we can do with partnerships, especially in the case of Brazil, have helped us to move forward in our actions within the Ministry of Health and the other ministries who are part of our plan. We could only be successful in this, we could thanks to this support we have received from partners. We had a series of online trainings, campaigns, to raise awareness here, especially with the support of the Pan American organization. We had more than 5,000 professionals, health professionals, for trainings and for quality management, web classes, talking about AMR, bacteriology, presidential trainings for surveillance, and a series of webinars also to talk about the World Week on AMR and the National Day for Rational Use of Drugs. The Ministry of Health also prepared from 2024 some infographics, lots of didactic materials to be distributed to the population. From the point of view of research, once again, the importance of partnerships so we can understand what Brazil needs, understand what our fragilities are, to build this surveillance, this attention to the patient, something better structured. So Brazil adhered to GLASS in 2018. We had a series of investments for the national network of laboratories with internal capacity of surveillance and understanding of AMR. We also invested on genomic surveillance. And with that, we could translate our data into some epidemiological bulletins, scientific papers, so this can be disseminated. From the point of view of research, a strong partnership with the Ministry of Science and Technology and also the Ministry of Health for strategic service. We series of research projects on AMR, which totals more than 120 million reais and 42 million reais, sorry. And we also made our contribution on the global AMR R&D. So we have now the hub, so we have an international participation in this context. These are some of the works that were carried out in these partnerships and are ongoing. This is an example of the work that the National Surveillance Agents, these are AS, on AMR for the infections, with its plan, the National Plan for Prevention and Control of the infections related to it, to monitor more than 2,000 ICUs and also dialysis services. From the point of view of rational use of antimicrobials, the role development by this together with the National Agency for Surveillance here, we would like to highlight the National Committee for the Promotion of Rational Use of Drugs, especially in our RENAME, which is the national role for essential medications, and the reverse logistics in order to collect and have some health units where the population can take, they can discharge drugs in order to avoid these drugs to be discharged inappropriately in the environment. This is the surveillance based on sewage. This name of the project is Revirai. We have the support of CNPq. This is, there are participants all over the country. It's really disseminated throughout the country.
Esse é o projeto Vigiran.
This is the Vigiran project supported by CDC,
E que é
and it is a project for the implementation.
apoia o Ministério
It
da Saúde
supports the Ministry of Health in order to understand the needs
como
of the surveillance and how to structure that surveillance better. So there is a series of capacitations, quality management, capacitation, training of professionals,
Ministério da Saúde
and the Ministry of Health incorporate this knowledge into their
na sua rotina,
routine
né, e na sua demanda, no seu orçamento.
and their budget and demand. So this project, we have a net of sentinel hospitals and also participant laboratories, and we count with Fiocruz, Anvisa, Unifesp, LACEN Paraná,
Com o apoio.
and also the support, we receive the support from CDC.
Essa é a nossa rede nacional de
This is our national surveillance, genomical surveillance network. It's a project of the Ministry of Health, Fiocruz, and CNPq, together with the
criação da vigilância genômica.
genomic. It's a national network for genomic vigilance, surveillance.
E agora,
And now,
do que está sendo discutido,
talking a little bit about the proposals for the National Action Plan for the period 25 to 30.
começando por
Starting with the structuration, when it comes to governance, which was the creation of an interinstitutional committee of One Health under the decree.
o comitê ele é formado
The committee
por mais
is
de 20 instituições,
formed by more than 20 institutions, including ministries, some councils, foundations, agencies. So
nós temos aqui a participação
we have here the
da
participation of the Ministry of Livestock, Ministry of Agriculture, Education, Defense, Agrarian Development, Foreign Affairs, and so on. So this gives us an environment, an institutional environment for discussion, for prioritization in order to move on with these actions within this context of the One Health context. Here is the action line 5, which is to contain the emergency on AMR.
aqui a parte de governança,
Here, the governance, multi-sectoral governance for the AMR actions, also interlocution with the civil society, discussion, sustainability, implementation of the National Action Plan, and implementation of the actions in this One Health approach. So we facilitate in the tripartite interlocution, qualification, monitoring, and evaluation of the plan, prioritization of the actions, and also the decision-making process. This is also brings us the responsibility of discussion this from the point of view of the community, understanding that we need to advance with actions that will reflect the need of the community in the country, with the different communities of the originary peoples, indigenous peoples, the vulnerable populations, and so on. The plan also have a strategical alignment showing that resistance is not only an isolated action, but it is a strategy that needs to be in the national plan, the national policy for drugs, community agency strategy for the family health, and other projects. Creating this approach, also the bottom-up approach, and top-down. Our plan, the proposal is based on 4 strategic objectives: governance, awareness, and strengthening of these actions, proposing a national program to strengthen the legal basis, the sustainability for the AMR prevention, and working partnerships and synergy with the programs and the equity actions. So, to strengthen this knowledge and innovation scientific foundation, to establish a national list of pathogens which are priorities, some interventions based on data to improve the lab surveillance and the integration between AMR and climate change. For the prevention actions, to strengthen the wash measures, the prevention, access to drinkable water, such as washing hands, reinforcing the importance of campaigns and for hygiene, prevention and control of AMR, and also to structure multi-sector surveillance when it comes to AMR. And finally, the access to strengthen the rational use of drugs, understanding what the access to medication is, not only working a reduction, but really understanding what level or what need the population has when it comes to antibiotics, and a strong integration. So this attention, also diagnosis, lab diagnosis, the qualification of these services and optimization of diagnosis. That's it. I think my time is over. I would like to thank you once again. Thank everybody's participation. Without these partnerships, we wouldn't have made this progress. This is really critical for any country. This exchange, this experience exchange is not only connected to funding or financial, for you to enable this experience exchange, this knowledge exchange is really critical, so all countries can implement their plans, their national plans. Thank you.
Obrigada, André.
Thank you,
Temos
André.
mais uns minutinhos,
Well, I think there is time for a question. We have a question in the chat, André. Marcela Vieira wrote,
escreveu: Bom dia, André.
good morning, André. Could you comment a little bit on the subdiagnosis of AMR cases in Brazil and in the region, as well as what has been done or needs to be done to improve diagnosis? Marcela, the point, the subdiagnosis is one of the strategic objectives, objective 4, when we treat access to drugs and also access to diagnosis, quality diagnosis. And this is one of the priorities of the Ministry of Health, to expand their capacity of diagnosis in the health services, not only from the surveillance point of view, but also the health services in general. So this is a reality, we know. The country is diverse. Not everywhere we have the access to good to basic examination, so it can take some time. This is where you lose opportunity of treatment. So this is a point we have as a priority, the national global plan for the period. So to strengthen what the ministry did to invest in public health, and also the integration for primary attention and the private network.
Obrigada, André.
Thank you, André. Thank you.
Bem, aqui no chat,
So here in the chat,
não tem mais nenhuma
there
pergunta,
are
né?
no
Tem o
other
pessoal, a
questions.
Cláudia,
Cláudia is saying hello, Terezinha,
o
Brito,
Rogério Lima,
Rogério
dando aqui os
Lima
parabéns
here
direto,
congratulating André and all the
trabalho
team
sobre a resistência antimicrobiana.
for the
Obrigada,
works on
Rogério.
AMR. Thank you, Rogério.
Bem, então dando
So
continuidade
now
aqui,
to resume
ao
our
seminário,
webinar,
agora eu quero convidar
I would
aqui
like now
a
to
doutora
invite
María Ortiz,
Dr. María
Ela é
Ortiz.
coordenadora do
She
projeto
is a
Resistência
coordinator
Colômbia.
of
E ela
the
vai falar
project
um
in
pouco
Colombia.
sobre
She's
o
going to
impacto da
talk a little bit to us on the impact of this use of the milk on the inadequate use of antibiotics for
Doutora Maria, seja muito
swine
bem-vinda.
in Colombia. Dr. Maria, you are very welcome. The floor is yours.
Renata, muchas gracias.
Thank you.
Hola a todos, buenas tardes.
Good afternoon, good morning.
Buenas tardes. Consegue compartilhar tu apresentação?
Can you share your screen?
Parece.
Vale, ok. Bueno, muchísimas gracias por la invitación.
Thank you for the
Hoy
invitation.
les voy a contar unas
Today,
novedades
I'm
que
going
tenemos
to share
en
some
nuestro proyecto
advancements that we have in a project that is based on the use of antibiotics in pigs. As you know, the pig production is one of the areas that actually have more usage of antibiotics, and mostly at the beginning of their lives. And the general goal of this project is to make a reduction in antibiotics in up to 20% through induction in diarrhea in piglets, and we do that in up to 10 weeks old of the piglets. We did a study, almost experimental, where we had a control group, where we had the practices, the routine in farms, versus an intervention that was a strategic intervention that we have for the breastfeeding of the piglets to diminish how the usage of macrobiotics and the presentation of diarrheas in piglets. In this case, we calculated an amount of sample in 140 female pigs, taking care of them and the piglets, and we assessed 280 females and the babies, and we distributed in 5 farms. Those farms were in the main regions of pig production, were Antioquia, Meta, Dinamarca, and Valle de Cauca. You can see the distribution of the farms, and to be able to participate in the project where the farms were related voluntarily, we had to accomplish with some inclusion criteria, where we had some raising or full cycle with an inventory of more than 400. And when we selected the pigs, they had some and we assessed those females in 2-3 deliveries, and for those who had more than 14 nipples functional and some characteristics in the breeding. In this case, our goal population were the farms, as I was saying, the vaccinated females, and the piglets were in the maternity. In this case, we selected 2 and 3 delivery females, and for each of these pairs, we selected 50%. Something that is very important is the distribution of the sample was done through proportional for the distribution in each, through the inventory of each farm. So we assessed 2 groups, one control group, where we assessed everything that was routinary and everything that we had each of the farms, and the delivery and the breastfeeding of the piglets. and this including what was medicated feed that they will be probably using in this stage. And in our following group was intervention group, and where we did a strategy for reinforced delivery and care. Additionally, for us to get to know what were the pathogens and in the farms causing this in these piglets, we did a sampling of 30% of the 280 layers, where it included 400 for each age, 84 for breastfeeding, 5 and 15 days old, and those who were in first and second week, third, fourth, and fifth week old. Here we have the 40% of the, and we had the samples. The importance of this sampling and the goal, which is a biological sampling, where we had it to say, in order to guide the vaccination sample of each of the farms. And this was part of the strategy of the study. What we had as the physiological management and intervention, we had some actions in each of the stages, both in gestational area and postpartum. In gestational part, we did reinforcement in 73 and 93. Most gathered to the physiology of the mammal gland. We did some part of the each one of the evaluation of the situation of the animals, if they had any pathology that were able to, that could cause problems or pain. We did the strategy of the last feeding that they had was 3 hours prepartum, and in this intervention group, we worked with this without microbiomes. So this feeding that we use as a preventive way, we eliminated. In terms of delivery, we had the environmental conditions, both in maternity and where we had the female with the piglets, and we took care of that, the strategy and rotation of the babies, rotating each hour according to the weight, and took care of those who had lethargia, hypoxia, because we had to take them out. And something that is very important, non-manipulation of the babies. Things that could generate these situations for and cut and everything. We erased that in this part of this intervention group to avoid those practices or these questions that generate stress. In terms of postpartum, to measure what was the quality of the colostrum, we did some measurements of immunoglobulin, and we did this in refractometry, and we did this identification one by one to do the follow-up during the process of assessment process, and we did adoptions of some of them, and adoptions we consider it's a very common practice where the mother doesn't have amount of babies. We share this and we avoided that in the intervention group, and we did some weighing of the animals up to 10 weeks old, where we had at the moment where we assess the animals. In terms of results, we're able to see the two main pathogens that we saw in terms of the study was and the virulence option 2. These were both that we presented, and then after in very smaller proportion, we evidenced other like salmonella and other factors that Escherichia coli, and in total for the sampling, we had 164 coles, where 62 were from breastfeeding babies and the other present. In this case, we took 3 farms that presented the biggest amount of pathogens. Mostly in the farm number 5, we identified that it was the only one that showed this factor, number 18, and rotavirus. The other farms had a smaller proportion on the pathogens. This was useful for us to see how were we presented if the implementation that we're using was the same. In terms of results, descriptive, in the control group, we did only 1 vaccination and the breeding, and we had 2 types. The only difference that we can see, we want to see in these characteristics was the effective time on this, on the piglets. And this is very important because in the sense, the babies, the least they have this, the colostrum, they're going to reactivate much faster. And what we valorate is directly proportional to the less quantity of time that they intake of colostrum, we have survival. In this sense, we value the consumption of colostrum. In our group, intervention group, we had a difference of 171 grams on the opposed to in the immunoglobulin was the difference as well in favor to our intervention in terms of grade. We had the group, intervention group, the piglets earned 54 grams versus the control group. And in terms of diarrhea proportion, we had biggest diminishing in the intervention group versus the control group. When we compare the proportions of the piglets that had diarrhea, and it's very important here the use of antibiotics, because we're able to see that in our group, intervention group, we had an intervention that was very significant in terms of the antibiotic usage. So we had a relative in the use of antibiotics, and we explain, and in this protocol, if you agree how we are able to take care of this, and we took this preventive in the feeding that we shared with the, and the reduction of the presentation of diarrhea in this intervention group. In terms of presentation of diarrhea, we had in the different farms, we had a reduction that was very strong in terms of, for example, when we had 72 to 30%, in the 4th, we had 14 to 0%, and in the 5th, we diminished 73 to 45. So if we compare the control group versus intervention, we had a reduction, a difference of 50% through E, and this is very significant. When we review the facilitators and barriers and implementation of the strategy, we saw that, for example, in terms of facilitators, when we work with farmers, they have a high disposition to learn. We, beside that, we designed a strategy of training for farm personnel, and this is mostly when we intervened in this presentation with aims for these workers to be able to understand why and what for we were doing this, and for them to afterwards to see and to understand the context and the importance of these actions. Something that was very important as well was the identification of the pathogens for the diarrheas to improve the vaccinal scheme, and it was a recommendation that we gave everyone. And also, these contributed to the installations of each one of the factories, because some weren't the best, and make an improvement of biosecurity, internal biosecurity of each one of the factories, of the farms. And what we had in the implementation, I don't know if this is a factor that we have in Latin America, or maybe for us in Colombia, we are living this in this moment, which is the low rotation of people in the area of maternity. Many workers have these works and they rotate in their personnel. This leads to lose trained personnel. So this is a large barrier area. And in terms of Colombia, one of the barriers that we had was the low availability of food and innovation. Most of the factories in Colombia have a formula that is included. So make this to take out all these drugs, and it was very complex. This is something that is part of the culture. And many of the farms make adequations to these installations, and we had many failures in biosecurity and in area of maternity. And here we observe that the motivation of the personnel is very important to make these actions in the farms and people to be aware of why and what for. So this is something we work with the farmers to establish some of the incentives for the personnel to stay and to get motivated to do things, because these are very attractive processes on a daily basis. So people adequate to do some practices that can be bad, but to change this and do this kind of implementation is complex, and we need a lot of training and above all, to make people aware. And this is the lack of registration and analysis of information. And within then, and to the colostrum consumption was larger in this, and we observed a larger gaining, a reduction that was very significant of 50%, and this strategy showed that it is possible to produce without these microbiomes, and actions and the management in levels of farm. And we saw as well a difference in the usage of antibiotics, and 80%, and as I showed, explained by the colostrum. And it's not possible to do it alone. With the team, it is the team that is through Colombia and the agricultural system and the sanitary service that is elite. So thank you very much. I don't know if you have questions.
Obrigada, doutora Maria, pela apresentação.
Thank you, Dr. Maria, for your presentation. Congratulations for showing a little bit of this work and the results, the importance of the integration of human health and animal health to fight AMR. This is a topic which is extremely relevant, so thank you for your presentation. And I would like to thank also we have now representatives from the Amazon, Uberaba, and Minas Gerais. So thank you everyone for your participation in our webinar. You can ask if you have any questions, you can make comments. We are here reading the chat on the YouTube. So please make your comments and participate here with us. And now to continue to our series of lectures, I would like to invite Dr. Marica. She is a coordinator of projects and management antimicrobial in the National Centers of Public Health in Georgia. And she is going to talk about the implementation of guidelines in hospitals in Georgia for the reduction of inappropriate use of antibiotics. Dr. Marica, the floor is yours. You are very welcome. Thank you for your participation. And you have the floor now.
Good afternoon. Thank you very much to have the opportunity to present here. I will share now my presentation. So my topic is implementation of surgical antibiotic prophylaxis guideline in Georgian hospital to reduce the inappropriate antibiotic use. Everything began in 2020 when we started thinking about the stewardship. In Georgia, there have not been any stewardship programs. So in 2020, we had the Memorandum of Understanding on the establishment of partnership on antimicrobial stewardship in healthcare facilities and veterinary settings, which was signed between ICARS and the Ministry of Georgia. And from 2021, we have our first antimicrobial stewardship project, which was surgical antibiotic prophylaxis. Our collaborative goals were increased knowledge of medical staff about AMR and antibiotics, to develop guidelines utilizing modern approaches to promote rational use of antibiotics, to introduce modern diagnostic approaches and equipment, and to promote implementation of AMR with the One Health approach. As you know, as in other low and middle income countries, Georgia also suffers for high consumption of antibiotics and first of all, cephalosporins. Before we began planning about the stewardship project, we started searching which was the highest problem. And the usage of third generation cephalosporins, we had very high consumption of it. As you see, it's a bit older version, but it was similar for the rest of the years. We're using cephalosporins and most of all third generation, where we're not using first or second generation cephalosporins at all. So we considered to use the low-hanging fruit approach for the AMS, because when you begin doing the stewardship program, it is very important that the first project is successful, to say that it is doable for other projects. So we decided to do surgical prophylaxis. In the meantime, it was not as easy as it seems, but we did it. So we also checked the background of the problem in 2020. We took the medical charts from the different randomized hospitals of Tbilisi, and we saw that incorrect antibiotic was prescribed for surgical antibiotic prophylaxis in 55%. And the prolonged surgical antibiotic prophylaxis was seen in 80%, which you can see was very high percentage. So we began our implementation phases. It was it was ethical improvement and administrative tasks. Then we developed a surgical antibiotic guideline, and it was approved. It was developed from the WHO guideline, and it was approved by the Ministry of Health. And preparatory works were done first in 3 hospitals, next in 4, and then in 3 hospitals. We developed also data collection tools. It was a preoperative and post-operative to do the surveillance on surgical antibiotic, to do surveillance on surgical infections, surgical site infections. So this is our plan. Our main goal was to improve the quality of use of antibiotics for surgical antibiotic prophylaxis in the nominated departments of Georgian hospitals by achieving 60% compliance within the 12 months. And within the compliance, we mean 4 indicators. It was correct antibiotic, correct dosing, correct timing, and correct duration. And full compliance was the sum of these 4 indicators. Our secondary goals were to improve awareness and knowledge of medical staff about surgical antibiotic prophylaxis, to standardize the process of prescribing surgical antibiotic prophylaxis, and to ensure the sustainability of the antimicrobial stewardship program in the long term. We had the following interventions. It was availability of context-specific clinical guidelines. As you know, we had international guidelines, but when you're going to the hospital and you want to implement the guideline, it is necessary and very important to have the national one. And also the other and very important intervention was education and training on surgical antibiotic prophylaxis. All the staff who was included in the project, and not only in the project. And the strengthening the surveillance of infections and use of antibiotics. We had a lot of trainings, as I said, not only with the members of the project, participants of the project, but also with almost all surgeons, epidemiologists, and anesthesiologists of the hospitals. We had perioperative data collection, where we collected data about our indicators, 4 indicators. We had also post-surgical surveillance, where we collected data after the surgery, 30 days, about the surgical site infections. We did point prevalence surveys, which worked mainly as an audit, and we had also focus groups, which project participants. Where we established barriers and facilitators for the implementation of the process. We analyzed all the data separately for 4 indicators, and also together with the whole compliance. Now, I'm today presenting only choice of antibiotic and duration, because of my team is of the rational use, how we reduce inappropriate use. So you see that in the beginning, 2 from 10 hospitals didn't have the correct antibiotic at all. So it had 2 or 3 months for them to purchase the antibiotic in the hospitals. And only 1 hospital was in a very good level. The 9 hospitals had problems, and after the 12 months, they had better percentage in the choice of antibiotic. This is duration. The duration was more problematic, because all the surgeons think that the more is duration, the better is the outcome, which is not working in that way. You see on this slide that 7 from 10 hospitals have a lower than 60% the compliance of correct duration of the administration. And after 12 months of very intense trainings and studies, all hospitals had more than 70% of compliance in this field. And the last one is the overall compliance. It was the most difficult part to achieve, because in this field we had to have correct choice, correct dosage, correct timing, and correct duration. Half of the hospitals have 0 full compliance from the beginning, but in the end, we have more than 60% in all of the hospitals, which is quite good achievement. The project was fully aligned with the National Action Plan of the country, and one of the very important tasks is rational use of antibiotics and raising awareness and education towards antibiotics and AMR. And the project played a huge role in this part. The outputs in the end was educational program of antibiotics, AMR, and antibiotic stewardship program, which we have achieved. guideline, nationally approved surgical antibiotic guideline and protocol, national antimicrobial stewardship program. This stewardship program for the hospital. In the end, the surgical antibiotic prophylaxis inclusion is a national strategy on AMR for 2024 and 2030, and also in action plan 2024-2026. An AMS certificate, which was from ESCMID, which was gained by the participant of the project. So we learned a lot of lessons from this stewardship project. First of all, the low-hanging fruit approach works. It was success. The early involvement of key actors was also key success, because in the beginning, we didn't know that anesthesiologists were working such a huge role in prescribing perioperative prophylaxis. But with the first months, we learned about these, and they were also included in the process. So it worked very well. Healthcare manager support to secure the procurement of the first-line antibiotics was key success. Having AMS champion in all hospitals, and political engagement from co-development to implementation process was also key success for the project. And to take-home message from my presentation is that antimicrobial stewardship project is a doable in low and middle-income countries. By guidance and support from ICARS, it is vital in the process. Thank you very much for your attention.
Obrigada, doutora Marica.
Thank you, Dr. Marica. Congratulations on your presentation, on your work in the hospitals there in Georgia, on the right consumption of the antibiotics. It's a work that we need to do, and we need to strengthen here in our networks with the doctors, this awareness, to raise awareness on the use of antibiotics. Thank you for everyone who are joining us, people who are writing in the chat. Thank you for everyone's participation. And to continue now with our presentation, I would like now to invite Dr. Ilana Camargo. Dr. Ilana, she is a coordinator, associate professor of the University of São Paulo, and she is going to talk about the evaluation of humans, dogs, and household dust as reservoirs of methicillin-resistant staphylococcus in the community, and evaluation of air purification systems to reduce transmission of antimicrobial resistant bacteria. You're very welcome, Dr. Ilana. Thank you for being with us, and I will hand it over to you now.
Thank you very much. I will start here. I'm gonna show you some preliminary results because our project didn't finish yet. So we were invited to join this consortium in the work package to study the modulation of the airborne transmission. Teresa Koch was studying this in hospitals, Alex Busser in farms, and we decided to study in our own homes here in Brazil. And why household dust? Because the indoor environment is an important source of microbial exposure for its human occupants, and also the most important source of microbes in house dust are outdoor air and other outdoor materials tracked in the buildings, occupants of the buildings, including the pets as well, and the microbial growth on moistened construction materials. And among the dog feces are a major source of bacteria in outdoor air in the urban environment, thus indirectly contributing to the house microbiota, even when households have no dogs. So why dogs? Because by that time we noticed we had a huge amount of dogs in Brazil, almost 56 million dogs. And comparing to the Brazilian population, we had like 1 dog for every 4 inhabitants in Brazil. And since 2010, we have regulations for antibiotic use in humans, but we so far don't have a regulation for the veterinary sector, although we are working hard on that. So we also noticed many researchers had different results with antimicrobial resistant bacteria in pets and tutors So we were worried about that, and we thought that besides the direct transmission among tutors and dogs, could their bacteria be transmitted by household dust? So we thought, what are among us in our own houses, right? So our objective was to study the role of the dust-bound bacteria in the AMR spread, to observe the presence of antibiotic-resistant bacteria in house dust and their occupants' microbiota. Also to investigate whether house occupants could be colonized by MDR bacteria and contribute to the dust microbiota. Also, we wanted to investigate whether the use of an air purification system in-house could decrease the dust and dust-bound bacteria, and to verify whether dogs under antibiotic treatment could be carriers of antibiotic-resistant bacteria and contaminate the dust environment. So we had 3 groups of volunteers. We have volunteers with no dogs, with healthy dogs, and dogs under antibiotic treatment or very recent antibiotic treatment. So we collected nasal swabs, feces from the humans and dogs, and also collected the dust from the house during 14 days. Some assays are under, we are still doing, such as the genome of the isolates and also the resistome of metagenome of dust, but we did that twice. We collect all this before the use of the intervention system, and then we repeat those with the air purifier system in the house. The dust was collected using these electrostatic dust fall collectors provided by Alex Bossers, who was using the same approach in farms in Europe. So from this, we were able to collect the DNA and the bacteria and measure the amount of dust. We also purchased some robust purifying system, and we found this one that meets all the requirements for optimal performance with different filters and different items necessary to purify the air. And it also helps us to adjust, to set these different speeds according to the size of the rooms under study. So I'm gonna show you the results that we found from bacteria from the mannitol salt agar with and without antibiotics and blood agar, meaning that we will focus on the Staphylococcus methicillin resistant here. So we try to isolate from the material, biological material and the EDCs. And after we have some suggesting that they were Staphylococci, we did identification using automation system. Being the same species from the same house, we evaluated the clonality by PFG, and we also determined the MIC for different antibiotics that are very specific for clinical use. So here are the preliminary results. So here I'm showing to you that we didn't complete the group C of dogs under antibiotic treatment because it was really hard to find volunteers for this. Sometimes they give up because of the suffering at home, so they decide to leave the program. I'm gonna show you that when we use the air purifier system in the house, we put in the room where the tutor and dogs stay most of the time. And we evaluated the amount of dust in the EDCs. So we didn't see differences in the 3 groups in terms of the amount of dust before and during intervention. Looking at the number of bacteria per milligram of dust, we didn't see any difference too in the 3 groups before and during the air intervention. And then these results could be due to several reasons. For example, the rooms under investigation were not strictly controlled. We didn't ask the volunteers to change their habits, and also because in Brazil there are some houses that don't have a central ventilation system. The doors and windows are always open, so we can't control several things. And there were reports, for example, that the neighborhood was under construction, increasing the amount of dust. So there were so many variations that were involved here. And we believe these aspects are the limitation of our study regarding the use of air purification system. But then moving forward, could the presence of dogs influence the amount of dust in the houses? So we saw there was a correlation between the presence of dust of dogs in the group B, increasing the dust amount in the house. This could be because the dogs need access to outside. Maybe the windows were open all the time. And when we look at the bacterial load, so the number of bacteria per milligram dust, then we saw there were much more bacteria here in the group of the dogs without treatment compared to those under antibiotic treatment. And there was no difference here and the amount of bacteria per milligram dust. But then we changed our approach and we investigate in terms of DNA proportion. So how many, we tried to investigate how many copies of the 16S RNA gene, the bacterial DNA, there were per DNA extract from the EDCs. And then we revealed here that the groups with dogs had much more bacterial DNA from the dust than the groups without dogs. And also the groups with dogs under antibiotic treatment had much lower bacterial loads in the dust. So considering that dogs are the residents that most contaminate the household dust, we investigate their feces to make sure that this could be the same or a result of that. So we noticed that the bacterial load was lower in feces of dogs under antibiotic treatment than comparing to the group of healthy dogs. So regarding the isolates, we recovered isolates from dust from several humans, around 35% of the humans in group A, to 25% group B, and 35% from group C. Only 2 dogs, one from group B and one from group C, were colonized by methicillin-resistant Staphylococcus. And in the houses, we found these isolates in 70% of the house in group B, and then almost 50% in the other groups. They were all MAC-A positive, and because we found in dust, we decided to make sure we could detect the MAC-A in those dusts. So regarding the presence of MAC-A in the house dust, we show here that around 25 to 30% of the house had the MAC-A gene that confers resistance to methicillin present in the dust. We try to measure how much of MAC-A compared to the total bacterial DNA we had in dust, but we found a high range distribution of these ratios that made it impossible to make statistical analysis, and also not all the houses had the MAC-A gene. So we investigate the number of volunteers carrying the MAC-A gene in nostrils and feces, and we noticed that almost 50% of the humans had MAC-A gene in nasal swabs and also a little less in feces. But there were more humans with the gene than dogs. Dogs, only around 20% of dogs present the MAC-A genes in nasal swabs or feces. And here I show all the isolates we obtained. There were some pathogen bacteria, but these species were that we isolated were not methicillin resistant. We only found methicillin resistant Staphylococcus among those coagulase negative Staphylococcus, mainly from epidermides and hemolyticus. And this diversity may change after we finish the genome sequencing. But we found some evidence of continued nasal colonization with the same clone in human volunteers 15 days apart in 3 houses in epidermides. And there was no evidence of these clones in dust or dogs. They were colonized for long term. And also we found evidence of continued contamination of dust by the same clone 15 days apart with hemolyticus and saprophyticus. And here These results suggest that there was a vomit of these clones in or near the houses, constantly contaminating the dust. And the McA gene could not be detected in the human or the dog volunteers of this house. And lastly, we found an evidence of the presence of the same methicillin-resistant Staphylococcus hemolyticus clone in dust and human feces in one of those houses. So the household dust may have been contaminated by human microbiota or contributed to human colonization. And this was observed only in the second sample collection. Here I show you the overall susceptibility profile of the isolates per groups, group A, B, and C. And we see stratifying here in the top from the humans and the bottom from the dust. And we see the isolates from dust, there were much more resistant traits here. We found also many isolates resistant to erythromycin, followed by clindamycin. About the dogs, only two dogs. We isolated only two from two dogs. One from group B, from the feces, showing resistance only to erythromycin, and the isolate from the nasal swab from the group C dog. There was a resistance to erythromycin, gentamicin, and trimethoprim sulfamethoxazole, meaning this is already a multi-drug resistant isolate. So are they important? If we look at the hospital, because we don't have the community data enough to compare, but if you look at the hospital, the coagulase negative staphylococci are the most reported when we see the data from Anvisa of the catheter-associated bloodstream infections in adults in ICU in Brazil. And 60% of them were oxacillin resistant. So they are everywhere. They are among us. We need to live in harmony with them. So our preliminary conclusions here is that we were unable to observe a reduction in dust amounts and bacterial loads in the studied groups of houses in Brazil. There was a correlation between dogs' presence and an increased amount of dust in the house. And looking at the genetic materials of dust, we observed that dust of house with dogs presented more bacterial DNA than house without dogs. Dust bacterial contain less bacterial DNA when dogs were treated with antibiotics. These dogs also showed less bacterial DNA feces, but we need to remember that antibiotic treatment may also select for resistant bacteria. And we will look for this when we have the resistome of the dust that our collaborator Marcel will do in the Netherlands. In conclusion, dogs, along with other factors that can increase the amount of household dust, may contribute to humans and dogs' increased exposure to bacteria. We also found around 25% of houses with dust carrying McA gene. So far, we only found coagulase negative resistant, methicillin resistant staphylococci. And we found pieces of evidence of transmission involving dust. So household dust was an important methicillin-resistant staphylococcus reservoir, reinforcing the importance of personal hygiene and environment sanitation. So I'd like to thank all the postdocs and also my master's student, Luciana, who worked on this project. Thank you very much.
Obrigada, doutora Ilana.
Thank you, Dr. Ilana. Thank you for your excellent presentation. It's a work that is really important. And I think one of the few in this area in the countries doing a research, a study that relates really the interaction of humans with animals, especially those pets, because we have an increase in the amount of pets, cats, and dogs, and how much we still lack knowledge in this area when it comes to transmission of diseases and raising awareness. So it was an excellent work. Thank you and congratulations. We are going now, we are seeing in the chat once again for the ones who have questions, suggestions, comments. We are here following everything that you post. And so far, I would like to thank once again everyone who are participating in this webinar, people from hospital, CFM, CFMV. Thank you for your participation, guys. And to continue with our webinar, I would now invite Dr. Ernesto. Dr. Ernesto is associate professor at the Peruvian University, Caetano Heredia, and he is going to talk about interventions related to AMR in the region of Latin America and the Caribbean from 2018 to 2023. The gaps, the existing gaps for interventions, AMR-related interventions in Latin America and the Caribbean. Dr. Ernesto, thank you for your participation. Thank you for being here with us this morning, sharing a little bit of your work and your knowledge, and I will hand it over to you now. Thank you, Dr. Ernesto.
Thank you for the invitation to be part of this webinar. Good morning, good afternoon, good evening. And we're going to present the results of a study that was aiming to identify what policies, programs, and were implemented in Latin America and the Caribbean within 5 years, 2018 to 2023. The team, and as I mentioned in several of the presenters, was presented by people with diversity, several countries, generations, ages, institutions, and that worked very hard to include students from postgrad that participated supporting the process. So I wanted to begin showing the team and the work that was good, thanks to them, and the contribution for those, and the technical part that was very important for work. We're not going to get into the importance of the resistance that was very well covered at the beginning of this webinar. And basically to say that that has this problem, and in the efforts that has the meetings also, and we ask, what is going on in a meeting that was done in 21? The difficulty, they put into practice the concept of One Health, and the programs for assistance weren't very formal. And lastly, we lack evidence to feed the definition of one intervention for one national plan that is more effective. This last thing is what makes us ask the question, the investigation question on the interest to know what is that exists published in literature made by peers. We look for both big groups, especially because this is being worked stronger within the last few years. So we had to add within some spaces where we were able to add relevant information to see how we are doing. So this study looked for the mapping, scoping review, and revision, I guess, on everything, the articles that report to the implementation of a policy, a program, a project, or an activity that is explicit or contribute to reduce the resistance and are eligible in every sector that is done in this concept. The methodology, as I said, was scoping review, which is the revision that looks for mapping and see what exists, and we follow a PRISMA protocol to be able to get to the results we're going to show. We decided to use this as a database, PARMED, Way of Science, and HELAX, considering that we're talking about the Americas, and the literature, the gray literature was with international organisms, different types, FAO, WHO, WOHA, and it was through 2018 to 2023 to select the articles or the interventions we needed to contain what I mentioned, the report of one program, of one action implemented into the sectors, animal, agriculture, environment, or those who include all sectors and have as a goal the exclusions are directed to the studies that were looking for only the virus mycotic. We didn't have an exclusion based on language. This methodology, as you see, and is summarized here, and we have a lot of work in these 3 stages. And the 3 stages followed for the different, the gray, and reviewed by pairs. In total, we identified more than 4,500 candidates to be identified, and then after doing the revision of titles and summaries, we went to the 3rd stage of revision for these complete articles, and we had 74. 56 that were from peer review, and 18 that came from gray literature. It was important, the decision to look for articles, because the idea wasn't to do an academical exercise, but it was with solid basis to understand what we're doing, what we're publishing, and in terms of the implementation of these plans that we're talking about. And the politics do. There's several things that we didn't identify here because they weren't published in gray literature, but this is what we found. This is a study. This is analytical description that have information on the countries, design, and the studies. We divide them if they showed results, and we call that with assessment, and the interventions that didn't have assessment. Why? And these studies with intervention cover all these aspects on the sectors of the health, intervention, everything. And this is similar with assessment and generic, which sectors are gathered and which pillar, one health pillar, it corresponds. So the results, and this is what we found that could be interesting for us as Latin America and Caribbean to know. Most of the publications were from Brazil, Colombia, and Chile. In these three countries, we concentrate the largest number of publications, and Brazil and Colombia that are included in the revision we've done, and Argentina, Peru, and Ecuador and Costa Rica, and biggest amount of number out of interventions, public interventions. We only published a study in the Caribbean. In terms of the sector, and was human health, the study with results, 1% in animal health and 2% in environment. In total, we say 90% correspond to studies done in human health, around 9% in animal health, and 1% environment, even though we have two studies that are related to environment, one directly and one indirectly. If we relate the type of interventions in terms of pillars, we have 44% are related to stewardship, 50% stewardship, almost 20% with vigilance, surveillance, percent with capacity building, and 14% with infection prevention and the divisions and
de los tipos de estudios que hemos encontrado, 22 de ellos son de estudios cuasi experimentales, 20 son observacionales y 4 son
and 4 are experimental. It means to show some of the strategies in terms of the reduction of the microbial resistance. So what we showed more is the consumption of antimicrobial infection rate, mostly in hospitals, the appropriate use of antimicrobials, resistance, and the adherence to the guidelines. The study that we had is a secondary one, and we observed what we've been doing in Latin America and Caribbean, and shows, as we saw, that most of the interventions, we have few interventions that are published, because the question is on what's published. And most are in human area, and most are concentrated in 3 countries, and we don't have a lot of evidence in terms of published evidence of interventions that combine the sectors that have a focus in health, that is in practice. This is important to strengthen these focuses and to gather and in practice. Most studies are related to stewardship, surveillance, and control and prevention of infections. And this is what we found in the study information that we mentioned already. Thank you.
Thank you, Dr. Ernesto. Well, we have finished our cycle of lectures, the presentations. I would like to thank everyone for all your presentations. They were excellent. And now we're going to have the Q&A session, our discussions. We have some questions. Débora and I, by watching this, we have some questions as well, and I would like to now open a discussion moment for us and with some reflections. So first with André. André, based on the examples of interventions that you have worked with for many years, André has been working with AMR in the ministry there since 2016. He was the one who brought the National Action Plan, who started with these and all the discussions. So I would like to hear from you, André. According to your background, your experience with these intervention examples, where do you see a priority today to Brazil? What actions should Brazil prioritize for an effective action for the prevention and to tackle this AMR? Thank you, Renata, for your question. I have had the privilege to work in different sessions related to AMR, in addition to what would be our main area, which is the lab surveillance. But today, I wouldn't like to say experience, but it's like our priority should be to understand the impact of AMR in Brazil, because we are discussing and strengthening different areas such as surveillance, infection and control, control of infections, the integration, human-animal health. But I see that most of these interventions, they have the food, the country belonging, the understanding of the country in order to fight AMR. In that sense, the use of surveillance to understand what the gaps are, the knowledge gaps are, the understanding of the consumption, how this consumption is being done in the country, people who have the access, people who don't, and why they don't, and how we can work in order to improve that, to mitigate the situation. Dr. Ernest's study shows that even though we have technical scientific capacity in the region, we still need advances. We need a space from the scientific point of view when it comes to AMR. We needed to foster this capacity, these qualifications, because this is what is going to give us the support to our decision-making process. So I really believe, Renata, that today we have to understand what is the load of the disease in the country, the priorities with the contact with the community, the needs of the community, using the education tools that the existing education tools and the professionals, as Professor Ilana, who has an important role with the elementary schools. So we need to make advancements in that when it comes to this, to raise awareness so the community embrace prevention and control of AMR, using the material, human technical material we have in order to move forward with we have a communitary action with the support of the community, social support for the prevention and control of AMR.
Obrigada, André.
Thank you, André.
Só lembrando
And
aqui,
just to remind you all, Deborah, as just to remind me to thank Vanessa and Nick for their participation. They all helped us
Muito obrigada.
in this webinar. So
Também queremos fazer uma
we would
pergunta
like
para a
also
doutora
to ask a
Marica.
question to Dr. Marica.
Doutora,
Doctor,
diante do
facing and considering all the study and the project that you carried out in the hospitals there in Georgia, how do you see what was the added value, the value added of this investigation, this implementation had for you? What is the value of this implementation for you?
So the final value of this investigation and implementation process was that in all hospitals where we began implementation, we reached our goal. And also we did, our goal is sustainable. So after the project, we added it, we included in National Action Plan. And after the project, twice in a year, PPS is conducted for surgical antibiotic prophylaxis, and we're checking that it is sustainable. That this is the final value that we have received from the project. Thank you.
Obrigada, doutora.
Thank you, Dr. Marica.
Uma pergunta para o Dr.
A question to Dr. Ernesto.
Dr. Ernesto,
Dr. Ernesto,
na sua opinião,
in your opinion,
por que você
why
acha
do
que o
you
foco
think
do
the
teste,
focus on
de
tests
intervenções
of interventions
tem sido maior,
has
né,
been
no setor de
bigger
saúde humana?
in the human health sector?
Para poder responder con evidencias, tendríamos que tener un
To be
estudio
able
largo
to
a
answer
nivel
with
de
evidence, we
investigación,
needed
porque
a study
teníamos
because
una
with
de las
this observation, we had the opportunity
conversar con
to
colegas,
talk to
expertos de
colleagues,
varios
experts
países.
from several countries.
Una de
And
las razones es
one of
que
the reasons
en
is
salud
that
humana
in human
hay
health,
ya un
we
trabajo
have a work
más antiguo,
that is
anterior, hay un
very
anterior,
much older, previous,
perdón, un trabajo que tiene más tiempo
that it's more, has more time,
despertar la conciencia de la
and
importancia
to
del problema
raise
de
awareness
la
and the
resistencia
importance
antimicrobiana.
of the
También porque
microbiotic resistance, because in several countries that I know,
laboratorios
the
de salud
labs,
humana están
human health
capacitados
are very
en
well,
muchos países
better
que
equipped
los de salud
than many
animal,
other
sobre todo,
countries in animal health and public.
y porque
And
el
because
concepto
the
de una
concept
necesita
of public health need
el tiempo para poder
some time
hacer, pasar desde la
to go from
definición
the
a
definition
la práctica,
to
el uso
practice,
concreto
the
en la
concrete
acción.
usage
El
of the
proyecto
action. This project
contaminación
of contamination
de patógenos con
and
resistencia
pathogens
antimicrobiana
with resistance in Brazil, for example, shows how
interrelacionado
are interlinked
el ambiente, la salud animal
the
y la salud
environment
humana.
in human health.
Entonces, ese tipo de trabajos son los que tenemos que
This kind of work is
desarrollar,
what
pero
we
también
need to develop, and
desplazar
also we need to
trabajos
uh,
colaborativos. Bueno, me quedo ahí porque
send collaborative works, because
pienso que,
why do I
resumen, porque
think,
pienso que
in
hay
summary,
más
why do I
salud humana,
think
porque salud humana
I
se
have
enfoca
more
más
human
en
health?
tiempo, en
Because
tema, pero
we've been
se está
working more in this
promover
time, and we need to promote
con
this
mayor fuerza.
work with health stronger.
Now, taking the opportunity and the same question, I would like to open now to all the representatives, all the speakers. I see when it comes to AMR that we still have a lot to do when it comes to the environment, because when it comes to animal health and the food safety, there is some surveillance, a little bit more structured programs, not ideal, né? But there is something with more structured when it comes to AMR. But when it comes to the environment is still, when we talk to people that are related to the environment, I see some difficulty for them to see what AMR, what it is, and what is the relation of AMR with the environment. And then I would like to hear from you a little bit more about your view, how we can improve this awareness when it comes, we can raise this awareness when it comes to the environment. Renata, I don't know if I can. I would like to say that I do not work with the environment. I haven't worked it for long. Now we assess the environment in our study. This is where our own homes. And we have to remember that many genes of AMR comes from bacteria that are in the environment. And we always focus on hospitals because hospitals are the place with more pressure and the quantity of that. So I think that maybe we cannot forget that the environment is important, because as they are discharged in the environment, there is this selection. And depending on the type of animal that they are raising and the administration of antibiotics, which is lost, but that is discharged in the environment, you also have some selection. But we cannot forget that the environment, such as here, there at work, we study bacteria that are in the environment. And then how much is this going to be bad for us? So we have to understand scientifically this outside the hospital environment, because we have a lot of data about hospitals, but not the environment in general. So we have to remember that bacteria are out there, and we need to give some attention to the environment as well. Thank you, Ilana. Dr. Sujith, please.
Thank you very much. In addition to what was just mentioned, I think we need to realize that, as I mentioned earlier, that bacteria, soil, water, all have an interconnectedness with us and animals. And therefore, we need to look at it from 2 points of view. One is that there are direct connections. For example, you throw waste into water or pollution into air, and the issues with direct pharmaceutical pollution, for example, or directly from sewage systems into water systems. And that's a direct contributor. But there's also the indirect, where all our use, whether it's at the human level, the animal level, the food agriculture level, remember that the final overall resource end is the environment. So invariably, what's happening is the more we use in all our sectors, it is getting into the environment. And then remember, we survive on water, we survive on air, we survive on food from soil. And that comes back. So that interconnectedness and the planetary health issue means that actually all of us are contributing to the environmental issue, and the environmental issue hits back on us generation to generation, whether it's from the genetic point of view or from a phenotypic point of view. So that's why we have to do our part in each sector in order to protect the environment. And otherwise, it'll become a vicious cycle. Thank you.
Thank you, Dr. Sujith. Thank you for all your considerations. We have some more minutes. There are some questions that I will ask. I have a question to Ilana. Ilana, based on the results you had in your project, what kinds of interventions you see that must be maybe tested in this context that you showed us? Well, Renata, so we first thought that maybe simply having a purification system could improve this, but no, we think about the ideal world. We were thinking about the ideal environment, but people's houses are really dynamic. And we see in the literature that, for example, when one of the residents travel, the microbiota changes because of the person's absence. So as it is really dynamic, we couldn't see much difference with the use of the purificator. However, when we brought the purificator back to our environment, we see that it was clean. We saw the dust, but we couldn't find any. We had some points to consider, maybe, that would be when it comes to dust, the dust, there is bacteria in dust, and bacteria that are resistant to some antibiotics of clinical importance, they are present in our households. So I think that ensuring people to have a healthy environment, I think people need to be aware that they need some hygiene, so access to drinkable water, an awareness about personal hygiene, environment hygiene. And what we always guide people to do is to wash their hands, and not only in hospitals, but also at home, because this reduces transmission. And in our households, we have to send this message, to teach people how to have this hygiene in their households. I think it's more when it comes to have good infrastructure, when it comes to water and sewage, and raising awareness of the population. Thank you, Ilana. And now, talking about raising awareness, I would like to say some of the actions we have in the country, which around AMR. So we have some videos, Confessions of a Bacteria from Terry Canapaula-Sepp from Fiocruz, which is really nice. It's a very nice video, very dynamic one to explain to the population how this process works. We also have the papers from Dr. Ilana, Cloabacteria. I have the book here I was given by her, and some other illustrations that you made, Dr. Ilana, when it comes to AMR. So I invite you all to look for this. You can Google Cloabacteria, Terry, Confessions of a Bacteria, Confissões de uma Bactéria, and you are going to find this material in order to disseminate this knowledge to the public, to the people who do not have much knowledge in the area, a little bit more about AMR, how to avoid it. Thank you. Thank you, Doctor. We have a question to Dr. Sujith. Dr. Sujith, where do you see the priority for AMR, globally speaking, in the scenario that we have when it comes to the funding for infectious diseases?
Thank you very much. I think it's a very important question, especially considering what has happened in the last few months from a global health point of view. I think the important thing is that each country has competing priorities. And therefore, there are multiple issues, not just health. Remember, we're talking about issues of commerce, issues of education, issues of housing, issues of infrastructure, and the list goes on. Problems keep adding up to any policymaker or any member of the public. So we have to be wise with our money. And there's an additional challenge of AMR, and that is often people do not see it because it's a phenomenon rather than a disease. And most of the time in many countries, when one person probably dies because of a drug-resistant infection, there is no label actually saying AMR or the contributory factor to the death as AMR. And therefore, often money and financial mechanisms do not know how to deal with phenomena like AMR or complexities like AMR, which are across the sectors. And remember, in each sector, there are different issues of AMR burden as well as AMR economics. So in my opinion, there are two things which need to be done. One is in each sector with each issue related to AMR, we need to ensure that there is some element of implementation research which brings about a study on the behavior and the economics, but more importantly, what are the interventions out there which are cost effective in that context? If we bring in that kind of a cost input into our studies and the research we do, it's much more easier for policymakers to understand these things and realize, okay, this is going to cost the country or the region or the hospital or the farm this much money if I don't do something about it. And of course, the intervention cost. The second is to make the right investment case, especially when we have competing priorities. And we've got to put things into perspective by saying that if you don't do something, this is the cost of inaction. If you do something, this is the cost of action, and compare that in each sector with each issue. If you can do that with some economic models and investment case, then I think we might have a chance to compete with other priorities and get the financing that AMR deserves, and get the financing that the national action plans deserve, and get the financing, most importantly, to ensure that we really move forward in our battle to contain AMR. Thank you.
Obrigada, doutor.
Thank you, Doctor. Well, so just to close, one last question to Dr. Maria Ortiz.
Doutora Maria, diante do projeto, né, mais ou menos ali o mesmo raciocínio que nós
Now the same idea we asked to Dr. Marica. How do you see, what was the value added of this investigation you carried out in swine, in the pigs there? And what is the value of the implementation of this work that you did?
Gracias, Renata.
Thank you, Renata. Recently, we communicated some results to the farms, but what is important is to change the thinking and awareness for producers that is possible to produce without, that we can make a reduction of risks, and that we can have an improvement in the conditions of biosecurity and the management of farms, and doing a reduction of usage, mostly leaving those that were part of the preventive way and leaving them just for therapeutic treatment when actually the animals are ill. So the results are very important for us and very valuable to change those paradigms and these concepts that are within the farmers, that many have the fear of taking the antibiotics out because they feel that their productivity is going to fall. But with this, we can somehow show that this is possible and we can make a change to improve what is public health in general. And for us as swine producers, we can include this in terms of the impact we can have in public health.
E doutora Maria,
And Dr.
qual, na sua opinião, né,
Marica, what in your opinion, Maria, Dr. Maria, sorry, what is the probability that PorkColombia would do this intervention that you tested from now on? Because we've seen that the results are important ones, very promising ones, and you have this perspective, maybe future perspective of integrating this intervention in the country. Dr. María del Pilar.
Sí, mira, nosotros estamos trabajando con el Ministerio de Agricultura y con el Servicio Sanitario Oficial.
We are working with the
para poder
Agriculture
hacer un proceso de escalonamiento
Ministry
de
to
este
make a
estudio,
scaling
a nivel nacional.
approach for this study,
Pero sobre todo para poder difundirlo.
mostly
Pero
to
ante
spread
todo
it
es que
and
podamos tener
also
y como
for us
sector
to
estamos
have as a sector, we
comprometidos
are
como por Colombia,
committed for
estamos
Colombia
comprometidos en poder hacer el
in be able
escalonamiento
to do
de
the
este
scaling
protocolo,
of this
¿cierto?
protocol,
De este estudio
this
en
study
otras granjas
in other
tecnificadas
farms that
en
are
el país,
technified
que
in the
realmente son
country,
las que mayor impacto
which are
a
the that
nivel de
have
producción
most
van a tener.
impact
Entonces,
in
estamos
production.
trabajando en este momento
And we're
en
working
ese
presently in
escalonamiento,
this
tanto con
scaling,
el Servicio
both
Sanitario
for
Oficial de Veterinaria
sanitation,
como con el
veterinary,
Ministerio,
and ministry
para poder empezar
to
a
be
hacer ese
able to
escalonamiento.
do this.
Y que
And
otras granjas en
other
otras granjas se
farms
pueda hacer la implementación de
can
este
do the
protocolo,
implementation of this
mejorando
protocol,
manejo y
improving
mejorando medidas de bioseguridad.
management and biosecurity measures.
Obrigada, doutora Maria.
Thank you, Dr. Maria.
Rogério Lima, né,
Rogério
que
Lima
se
from
intrometeu aqui no
Parro commented
site,
here on
link, né,
the
do
link, YouTube link,
que a
a
OMS
document
publicou
that
junto com a
WHO published with
Unesco,
UNESCO, FAO, and
sobre
UNONSA
prevenção da
about the
resistência
prevention of AMRs and the sensitization in the different scales of recommendations for those policymakers.
Então, se você,
So if you,
não sei, Rogério, se você tiver o link,
I don't know,
quiser
Rogério, if you
colocar
have
no
the
chat
link,
também,
you can
para
pop
podermos
it in the
acessar
chat
esse
so
documento,
we can
agradeço
all access this file.
compartilhar
Thank you for
conosco.
sharing.
Bem, aqui
Well,
nós já estamos chegando ao final.
we are
Antes de
getting
encerrar,
to the end, and before closing, I would like to thank to Deborah Kulik, Vanessa, Annie,
por todo o apoio, né? A Débora, ela correu muito atrás.
Deborah was really working hard backstage, the organization with the speakers and all the structure for the webinar. Vanessa, thank you for your participation and your commitment. Thank you, Anik. So we had this webinar today. Thank you, everyone, for participating, for your presence. André, do you have any final message?
Obrigado, Renata.
Thank you, Renata.
Também agradecer,
Just
né,
to
pela
thank
sua
also for
generosidade de compartilhar
how
as
kind
informações.
everyone was when
Acreditar
sharing their
que
things. And
sem
I would like to
uma
say that
rede,
without a
parcerias,
network,
de
this
solidariedade,
partnership,
de compartilhamento de
solidarity,
conhecimento,
sharing
muito
knowledge, it
difícil,
would
o
be
caminho é muito mais
difficult.
difícil
It's
para
a much
poder
more difficult way
combater
to
a resistência
fight
aos antimicrobianos.
AMR.
Outro ponto,
And
resistência ela precisa ser entendida como um
this
problema
resistance
complexo
has to
que
be
tem que
understood
ser
as a complex problem.
ligada, né,
And it
aos
has to
avanços
be
da
related
cobertura
to
geral de saúde,
advances for the
né?
universal
Desenvolver
health coverage. We have to
resistência a
show
antimicrobianos
that
para
this
conseguir
AMR is only
combater
possible to, it's only possible to tackle AMR with the
universal à saúde.
advances.
Mostrar que parte
Show that part
dos vários países, né,
of the many countries, bacterial
pela
infections are
morte de
responsible
neonatos,
for the
bebês,
death of
e que
newborns
parte
and
dessas
mothers,
são
and
causadas
part
por
of these infections
são
are
infecções
caused,
resistentes.
are
Então, a gente
resistant
precisa
bacteria. So we
trabalhar
really need to
nesse
work
sentido.
on that
Então, no
sense.
acesso ao serviço de saúde de qualidade,
The
ao acesso à
access to
informação,
this information, to quality service, to generate information, generate our
E essa
knowledge.
iniciativa,
Thank you, everyone. This
Brasil
initiative,
iniciou essa iniciativa
Brazil started
de
this,
traduzir, né, de
translating
fornecer a tradução
and providing simultaneous interpretation to Spanish and English to the webinars, so we could have the participation of our colleagues, our friends from different parts of the world. So we are very happy to welcome you all in this webinar.
Obrigada,
Thank
André.
you. Thank you, André.
Obrigada a todos os participantes.
Thank you
Obrigada
to all
por
the
todos os
participants.
participantes.
Thank you
Mais
to
uma
all
vez,
the speakers.
parabéns
Once
pelas
again,
apresentações,
congratulations on your
de excelente
presentations. They were
qualidade. Parabéns
all
pelo
excellent.
trabalho que vocês
Thank you for the work
né, na parte
you
de
are doing
pesquisa, de
in your
políticas
research,
públicas.
public
Realmente é um
policies. It
privilégio
is a
poder
privilege
esse momento com
to share
vocês.
this moment with you.
Agradeço a todos que
Thank you
assistiram
for
também
everyone who watched it on
Obrigada pela
YouTube.
participação.
Thank you for your
Vocês
participation.
que estão na ponta, né, que realmente
You
fazem
there
esse
in the
trabalho,
on the field, on the
efetivo de
ground,
combate e prevenção da resistência
doing this
antimicrobiana.
work for
Muito obrigada
effective.
por
Thank you for
por
being
estarem conosco nessa
and for
manhã.
taking your time with us
Então,
this morning.
encerramos aqui
So now
esse
we are
webinar.
closing this webinar
Agradeço a todos.
by thank you, everyone. I wish you all a great day and a great week. Bye. See you guys.
Chao.
See you.
Gracias.